A very good evening to you and welcome to tonight's My Macular and Me webinar. My name is Kathy Yelf and I'm the Chief Executive of the Macular Society, and it's great to have so many people with us this evening, even though it's still light outside and the weather's at least a bit drier than it's been where I am. Anyway, I hope it is where you are too. Great to have you with us, as I say. So I know that many people are acutely interested in any possible news about effective treatments for the forms of macular disease that are currently untreatable, and there are quite a few of them. As you'll know, the NHS currently has no treatment available for dry AMD. But as you'll also know, if you joined previous webinars, there are some promising drug treatments in the pipeline, and we're keeping our fingers crossed that we may hear more positive news about those later in the year. But of course, drug treatments are not the only avenues that are being explored as potential therapies. There is now a lot of interest in the action of light, or at least certain types of light, on the progression of age-related macular degeneration. And some treatments are in fact being offered in the private sector already. But what do we know about these treatments? Why might they work? What's the theory behind this? And what evidence is there that they do work, in fact? Well, tonight's expert guest is going to be able to help us answer some of those questions, and I am delighted to welcome Professor Tim Jackson, who is an NHS consultant ophthalmic surgeon at King's College Hospital, which is a very large teaching hospital in South London. There he undertakes cataract surgery, but he also has a subspecialty interest in macular and retinal diseases and surgery on the retina as well. He's also a professor of retinal research at King's College London, which is part of the King's Health Partners. And in fact, this is the UK's largest academic health science centre. So Tim is going to give us a great talk, as so many of our guests do. And then, of course, there will be time for you to ask questions. So we've had some questions in advance, but please, if you've got questions during or after the talk, pop them into the chat function and we'll get to as many as we possibly can before the end of the webinar. But Tim, welcome. Thank you so much for joining us. It's great to have you with us. Thank you very much indeed.
Good. Well, thank you, Kathy. Thanks for the invite and thanks for the intro as well. So I've done one of these before, actually. I think they're great meetings. I think it's really nice to be able to sort of kick a ball around and have a think. We're more than happy to field questions at the end. But I'll run through the slides. Apologies for those that can't see the slides. They're more really for my sort of memory, so I can talk about things in order. I'm going to share the screen now. So let me just bring this up. I'll just check that you're able to see the slide.
Absolutely perfect. Thank you.
Good stuff. Okay. So we're talking about photobiomodulation, which is a kind of the overarching term for this new kind of treatment. And I want to sort of give you an outline of where we're going with the talk. So I'll have a think about what is photobiomodulation. This is it's a bit dry, I'm afraid. It's a sort of slightly scientific kind of discussion at this stage, but think about what's the biology behind it and why might it work. I then want to move on to think about how it relates to age-related macular degeneration, and I've no doubt that a good proportion of the audience have got AMD. And then we want to try and link those two together. So what goes wrong with AMD and how might that be amenable to treatment with photobiomodulation? And then really, I think we're getting into the specifics of it, which is the Valeda system, which many of you will have heard about. And I suspect that's the underlying prompt for this meeting, because many people will have heard the promotional material about this and just want to know a little bit more. So to get into the specifics of that, I'm going to go through the trial. I'm going to have a look at the main, there's a series of trials, but I want to focus on the main trial, which is LIGHTSITE III. And I'll go through the results. I'll have a look at the pros and cons of the trial, and then we'll sort of try and draw things to a conclusion and think about what future research might look like. So I want to start with the mitochondria. This isn't going to be a school science lecture, but I think it is helpful to have a basic understanding of the mitochondria, from which you can sort of build up how the treatment might work. So we have our cells, which are the sort of individual units within a body. And inside virtually all of the cells, there's these things called mitochondria. And they're like the powerhouse, the organ within the cell that generates power for the cell. So they consume oxygen and then they generate ATP, which is a sort of biological currency. It's the fuel of the cells. There's a very sort of interesting background to these. So the thought is, and there's pretty good evidence in support of it, that these were once bacteria. So when our cells were sort of at a very simple stage, literally millions of years ago, they gobbled up bacteria. Now, normally they would just destroy them when they got inside the cell, but for some reason that didn't happen. And the bacteria existed inside the main cell, and then they formed a sort of symbiotic relationship. And effectively what happened is that these bacteria became part of the whole cell, and then they were reproduced with the cells, and they became an organelle within the main cell itself. A lot of evidence for that. They have a double cell wall, which kind of means that when they were sucked into the cells, they took an envelope of the cell's own coating. They've got their own DNA. So again, this DNA looks very similar to bacteria. They divide like bacteria within the cell, and they've got their own organelles, their own sort of structures within them that would suggest that they were once their own sort of living cell. So an interesting sort of background to these, but they are hugely important. The question then is, how does that matter in terms of AMD? And I want to go through some of the evidence that suggests that mitochondria are probably fairly pivotal to AMD. It's not to say that there is one cause. We know for certain that there are a number of problems that underlie AMD, but mitochondria are probably fairly central. That makes sense. Every cell needs energy. And if there's damage to the energy creating mechanism within a cell, that's going to leave the cell vulnerable. So in terms of the evidence that mitochondria are damaging in AMD, there's a number of molecules that contribute to AMD, but one of them in particular, these things called reactive oxygen species. These are really potentially quite violent molecules that exist within the cell, and the cell does a lot to keep these under control. But mitochondria can produce these reactive oxygen species, so they have the potential to cause real havoc if things are deranged. Conversely, the ROS, as they're called for short, can damage the mitochondria. So you can set up with a vicious cycle there where the ROS damages the mitochondria, which then creates more of them, and onward and downward. So what's the evidence that AMD might have a mitochondrial dysfunction? And I think it's reasonably convincing. If you look at people with AMD, and you compare them to people who don't have AMD of similar age and background, what we find is that the patients with AMD have mutations in their mitochondrial DNA. So if you remember earlier, we were talking about these mitochondria having DNA within them. Well, these DNA seem to be damaged. They don't function as well in patients with AMD if you compare them to other patients. The chemicals within the bloodstream can be sampled to look at whether or not the mitochondria are under stress, and we find with AMD patients that they are. There are gene defects within the mitochondrial DNA, and there are abnormalities. If you look at these under electron microscopes, see these are often quite sort of exciting images you see of sort of house dust mites and things like that, these big angry looking insects. You can use those to get incredibly high resolution scans inside the eye, and then down to the level of the structures within a cell. And when you look at the mitochondria in patients with AMD, often the mitochondria are disrupted. So let's assume that that's all true. Well, if that's the case, then what can we do to help the mitochondria? So photobiomodulation, or sometimes just PBM for short, is something you need to think about, both the pros and cons. Now, we know in the Macular Society have done a lot of really good work in terms of trying to explain and think about how you avoid damage from light. So light can cause damage to the eye, and so often advice is to wear sunglasses or a cap if you're in bright outdoor conditions. So I don't want to undo that advice by saying light is good. It's not as simple as that. The high energy, short wavelength light, so those are the kind of the blue end of the spectrum, can be definitely damaging to the eye. So we still want to protect ourselves from that. So it would seem counterintuitive to use photobiomodulation. In other words, using light inside the eye, you would think would cause more harm than good. But the reason it works is that it tends to use a very different wavelength of light. They tend to be at a different end of the spectrum, and I'll sort of talk more to that in a moment. And it's a very low level light energy. So it's designed with specific wavelengths. And we think that at these kind of lower levels, it actually stimulates cellular function and can produce a benefit. It's used across a range of different fields. It's used in pain management. So I've just given an example of one of each in this case, but arthritis is sometimes treated with it. It's thought to help wound healing. So the mitochondria, as you imagine, healing a wound is a very energy intensive process. And if you use if you can sort of improve mitochondrial function, then we can potentially improve wound healing as well. Inflammation is a very common process throughout the eye, but it can, at least it's reported, to improve and reduce inflammation as well. It's used for skin conditions such as acne. It's used in dental conditions, so inflammation inside the mouth. And there's also thought to be benefit for some neurological conditions such as stroke. Now, a lot of those processes are very similar to the processes that underlie AMD. So we know that AMD can be considered a wound healing process, and there's inflammation as well. So it's not implausible that they could have some benefit for use inside the eye as well. So just digging a bit deeper into how it works, it's worth just thinking about what light is. Light is a form of radiation, if you like, and it exists across a spectrum. So the colors that we see in the rainbow are stretching from sort of red at one end to the blue and purple at the other. And then there is wavelengths of light that go beyond that we can't see. So ultraviolet at the blue end and infrared at the red end. Now, not all, but most of the devices using PBM work at the red and the near infrared. So that's visible red, so you'd be able to see the light treatment, and light that goes beyond that you may not be able to see, so-called near infrared. So why would this help mitochondria? We know a lot, and there's also a lot we don't know. But what we find is that when the mitochondria are exposed to light, they absorb, there's a chemical inside them called cytochrome C oxidase, and that's a molecule that helps generate the ATP. It's part of the process that takes in oxygen and converts it to produce the ATP. But this key molecule within this, within the mitochondria, absorbs light, and it seems to increase the function and the ATP production. So it does something to kind of restore the mitochondrial damage. Remember, we were talking before about these reactive oxygen species, and as I say, they are very important. And ironically, or perhaps counterintuitively, the light increases these ROS. Now that should be damaging, because we don't want these potentially damaging molecules in the back of the eye. But it seems to be that a small increase in these ROS actually may promote a repair process that helps in AMD. But clearly there's a balance here. We've seen already that light can be both positive and negative. The ROS potentially can be positive and negative as well. So with any treatment that has this kind of the spectrum of activity, you need to think about safety as well as how effective it is. It's thought that light can release some chemicals. There's a molecule called nitric oxide that is released in response to light, and that increases the blood flow to the eye, which may well be positive, because there's some thought that a lack of blood supply is relevant to the AMD. It may also reduce some of the chemicals that cause inflammation. There's molecules called cytokines which cause inflammation, although some of them in fairness can dampen it down. And the thought is that light increases the good cytokines and reduces the bad ones. And between the two of them shifts the balance that can reduce inflammation inside the eye. That again would make sense for AMD, given that that's contributory. So then, dealing now with the specifics of the system itself. You remember the spectrum we spoke about before, and what we find is that this device is designed specifically for AMD. A lot of the other devices can be used for various purposes. This is one is designed specifically to target AMD. It uses 3 wavelengths. So 2 are visible. So you can see there one, the sort of the yellow spectrum at 590, which is the wavelength of light, and that corresponds to the color. If you increase the wavelength a bit up to 660, it moves into the red spectrum, and you use those 2 wavelengths. And then there's a third wavelength, which is beyond what the human eye can see, about 850, at the sort of in the near infrared spectrum. For those of you that can see the picture, there's a image of a woman sitting with her head on a chin rest, having the light shone onto the eye. And what seems unusual is that for part of the treatment, the eye is open. That's for these lower wavelength lights, but actually the longer wavelength lights can pass through body tissues, and that's why they're used for treating arthritis. You can't reach the joint unless you have some tissue penetration. And because of these longer wavelength lights have very good tissue penetration, the patient can actually be treated with their eyelid closed, which seems very bizarre to have a treatment with your eyes closed, but there is science to that. it's not as if you're going to just have one treatment and that's going to produce a change in itself. The treatment is a regimen of treatment, so there's different cycles of treatment. Now, the device is licensed in the EU, which is why we're seeing it on the market now. It's not licensed in the US, but as I understand it, the company are seeking a US license. Oftentimes, people think that the license, if it's licensed, therefore it works and it's good. The licensing process doesn't necessarily tell us everything about how safe or effective a device is. It meets certain criteria, but it doesn't necessarily prove that it's the final determination in terms of how good or bad a technology is. And as I say, we'll wait with interest to see how the US regulator decides in terms of whether or not this is something that should be licensed or not. But it's important to understand that just because something is licensed, you still need to look at the evidence and decide if it's a good or a bad treatment for you in particular. The other thing just to take on board with the licensing is that the licensing for devices, as opposed to drugs, has generally a very different burden of proof. The drug companies will have to do usually enormous clinical trials to a very, very high standard to get a license to sell their drugs. The burden of proof for devices is much less. There are pros and cons to that. One could argue that the devices should be held to the same rigorous standards as drugs are. That would, at face value, make a lot of sense. It would ensure that patients are well protected, that they're only sold devices that we know are extremely effective. On the other hand, the companies that develop these devices don't have the deep pockets that the drug companies do. So for them to run a trial of 1,000 patients may mean that many really very good technologies would just fall to the wayside because very few would have the funding necessary to get across those hurdles. So there's a very difficult balance that the regulators have to make between shutting down all technologies and denying them to patients, but on the other hand, being sure that the standard meets a minimum criteria that allows it to be to sold to patients. So looking at the system itself, typically the treatment is done by a trained staff member, which could be a doctor, it could be someone with clinical experience under a doctor's supervision, or it could be an optician. Oftentimes, doctors will be a little bit protective about people offering a treatment. Maybe that's ego, maybe it's, well, who knows what underlies it. But in fairness, this is a relatively simple treatment. I don't think the delivery of the treatment calls upon exquisite surgical precision, for example. The device will cover most of the sort of algorithm fairly reliably. So I don't think there's anything wrong with medics not providing the treatment. The only thing I would argue is I think it's probably useful to have a medical opinion as to whether or not treatment is indicated. So does the patient need the treatment, I think is a clinical decision. But I think the delivery of treatment doesn't require a doctor to do that, in my personal opinion. Treatment takes about 5 minutes per eye. It's not particularly arduous treatment. There's no pupil dilation. So I'm sure that many of the people listening in today have spent many hours in AMD clinics up and down the country for wet AMD. And they'll be very familiar with pupil dilating eye drops. But the technology doesn't require that, which is nice. So the patients won't have blurred vision as a result of having had dilating drops put in. It is, however, a fairly intense treatment. There's 9 treatment sessions with a degree of flexibility in terms of scheduling, but about 9 treatment sessions, so a fair number over about 3 to 4 weeks. And then the treatment is repeated about 2 or 3 times each year. So it's a good number of treatments, usually about, say, maybe 9 treatments a year. I've done a little bit of digging to sort of try and find out about cost. Lumathera suggested that it's in the region of $1,000 to $2,000 per cycle. But if we look at the clinical trial, you're looking at repeating that about 3 times a year. So, you are talking in the region of maybe £5,000 a year for treatment. So it's not cheap. So I want to move next to have a look at the LIGHTSITE III trial. Now, there were some background studies that were done before this, but these were generally fairly small. And the company will sort of put forward LIGHTSITE III as the pivotal, definitive trial in terms of showing whether or not this works. But it is worth taking on board that there's a trial in isolation, even though it is the main trial. It had 100 patients, which was, in a sense, quite impressive in that it was recruited over the COVID period. It was very difficult to run clinical trials through COVID, so getting any patients recruited in the context of COVID is no mean feat. So, we have to I congratulate the trial team for making this happen. There's some patients had treatment in both eyes, so 100 patients and 148 eyes. Patients are randomized to active or sham treatment. By sham, I mean sort of fake or placebo treatment, so the patient wouldn't necessarily know, or it was designed not to know, let them know whether or not the treatment was real or not. And that's important in terms of trial design, to make sure that everyone's being objective in terms of how they measure outcomes. And that masking, again, adds to the rigor of a trial. So if you can randomize a trial and make it masked, then we have much more faith in the outcome of the trial. What's very important, I think this is just something for everybody to pause and think about, is whether or not, if someone is considering this technology, whether or not they were the same as the patients on the trial. Whenever you design a clinical trial, it's very, very important that the patients who have the treatment were the same as the patients that were on the trial. Because if you're not comparing light with light, then you really don't know whether or not the technology is safe and whether or not it works. So it's really important that if patients are considering having this technology, they have watertight reassurance that they were the same type of patient who was entered in onto the trial. Because if not, then there isn't proof the technology works. So the patients had to have dry AMD. Again, there may be many patients with wet AMD on the meeting, but I'm afraid it was excluded patients with wet AMD. The vision had to be between 2032 and 2100. Those are US metrics, but I think it's the closest that anybody's familiar with, the so-called 2020 phrase. So 2020 doesn't mean perfect vision; it means normal vision. So 2030 is sort of moderately reduced vision, still be good enough to drive. Through to 2100 vision, which is really quite poor vision, wouldn't be sufficient to drive. You'd still have visual function, but it would be significantly diminished. The drusen, which are these little yellow deposits in the back of the eye, for those that can't see the images on the left, these, if you look into the very back of the eye, you see these little yellow deposits sitting underneath the retina. They're a telltale sign of AMD. Now, lots of people have a small number of very tiny drusen. The patients on this clinical trial had medium-sized drusen, so it's important that you confirm that you have drusen of this size before considering the technology. Patients could also get onto the trial, though, if they instead or also had non-central geographic atrophy. Now, by that I mean an area in the back of the eye where the cells have died away. So for those that can't see the picture on the right, what we're looking at is an area where there's a punched out area of cells in the very back of the eye, and those cells don't regrow, but they can, that area of absence, that area of geographic atrophy can expand and damage the vision. So we don't want geographic atrophy, but the patients were eligible if they had some GA, as it's called, but not if it involved the very center of the eye, the fovea, where the light comes to a focus. Because if you have GA in the center of the fovea where the light comes to a focus, then the vision is usually poor and maybe irretrievable, sadly, at that stage. So these were looking for patients who had GA, but not involving the foveal center. So again, very, very, very important that you make sure that you fit these criteria if you're considering the treatment. So looking then at the results of the trial, there are a number of trial results reported, but it's very important when you look at the trial results that you check that these trial outcomes were pre-specified. What you don't want to do is look at a trial and they've reported lots of good things, but actually they weren't the metrics, the outcomes that they were planning to look at, because otherwise what you can do is just take lots and lots of measurements and just pull out the results that are favorable and ignore those that were not. So it's very important that when trials are reported, that there's a rigor in the reporting and that the outcomes that we're looking at are those that were pre-specified. Otherwise, you do have to take them with a pinch of salt. So the main outcome that was pre-specified was vision, or visual acuity, as we were talking about a bit earlier on. This is main outcome is at month 13, but the trial does continue to month 21. So if we look at the active group, these are the patients who had the real treatment. They gained 5.4 letters. Now, 5.4 letters is a measure of visual function, and a greater gain is a better vision. But these are relatively small numbers. So to put this into context, these 5 letters, if any of you have had your vision tested on an eye chart, the sort of normal eye chart that you might see if you go to the optician or if you're attending an eye clinic at hospital, 5 letters is the same as 1 line on the eye chart. So if you looked at the eye chart and you could read the letters at 1 line, If your vision improved by 5 letters, it would mean that you could get down to the next line on the chart and see the second row of smaller letters. So it's a modest change, but not to be ignored. One of the things that makes the trial more difficult to interpret is that the sham group, those that didn't get the active treatment that may have thought they did, gained 3 letters as well. So there's no particular reason why these patients should gain letter if they didn't have active treatment. Maybe there was some spillover of light or some failure of the sham, but that seems reasonably unlikely. It's possible. Or maybe that would just happen by chance. Maybe that's just a chance finding. It's not real. Well, maybe perhaps they got better at doing the vision test. Patients practice vision acuity chart testing as they go through the trial. So sometimes there can be a learning effect. Now, of course, you've got to take off that result in the sham group, because if the patients would have naturally got better anyway, that 5.4 letter gain isn't 5.4 letters. What we look at is the difference between the 2 groups of the trial. And what we see if we look at the difference between the 2, which is just simple subtraction, then there was a difference of 2.4 letters between the active group and the sham group. Now that's a small difference. Before we were talking about the difference between seeing one line on an eye chart and the next one down, then we're talking of half of that difference now. So 2.5 letters is a small difference, but because the study was well designed, it was masked, it was randomized, it's likely a real finding. And we use a number of statistical tests to establish if that was just a chance finding or we think it's something real. And the statistical tests that were done suggest to us that 2.4 letters, it might be a little bit more, or it might be a little bit less, but it's probably real. There probably is some biological benefit from having had treatment. Now, the question then is 2.4 letters going to make a difference to somebody having the treatment? Would they notice it? And 2.4 letters probably isn't something the patient would necessarily notice. We normally think that a difference of about 7 or 8 letters is at the point where the patient starts to go, oh, hang on, my vision is better now, I can see a difference. And of course, it also depends on what the vision is like in the other eye. If the vision is better in the fellow eye, then an improvement in the worse eye may not have any impact overall because they're seeing out of the other eye anyway. It's not to say we would ignore that difference. And keep in mind, it's not as if everybody gets a small gain of 2.4 letters. There'll be some patients who get a greater vision gain and some patients that don't get a vision gain, for example. And it's that averaging gets rid of that nuance, if you like. So it may well be that there are some patients who got a material improvement with treatment, but others didn't. And overall, that average is very small, but probably real. One of the things that's been sort of made some noise about within the trial is that the active group of participants were less likely to develop geographic atrophy. Now, we spoke about geographic atrophy before. That's this punched out area of cell loss that can be very damaging. So that's potentially of real interest, because expanding geographic atrophy, if it expands to involve the fovea, the bit I was talking about before in the very center of the back of the eye, if this expanding geographic atrophy expands to take in the fovea, then the vision will drop, and often quite substantially. So we like to avoid geographic atrophy. Now, the trial looked at geographic atrophy from what I've been able to delineate. The trial set out to work out whether or not this treatment would reduce the expansion of geographic atrophy. It looked at the size of the geographic atrophy, and the statistical test suggested it didn't make a difference. But there was a separate item reported which looked at whether or not patients developed geographic atrophy, which is a separate outcome. Very, very small numbers of patients. As far as I can see, it wasn't actually technically what was pre-specified, even though they were meant to look at geographic atrophy, but I may be wrong on that. It's hard to delineate from the paper. And then the important point is that's what's called an exploratory analysis. It wasn't the main aim of the trial. The trial wasn't designed in such a way that it could give certainty to any conclusions looking at a reduction in geographic atrophy. So all those things taken together mean that we shouldn't read too much into the finding that there were fewer patients developed geographic atrophy. We're very uncertain in that outcome because of the small numbers, the design of the trial, and because it was an exploratory analysis. So if you want to decide whether or not this treatment reduces geographic atrophy, then you need to run another trial. There's no way around that. So if we want to find out, does this treatment reduce the risk of geographic atrophy, then we have to start another trial with that as the main hypothesis, and then design the trial to answer that question. So in terms of the conclusions, I think LIGHTSITE III was a well-designed trial. It ticked a number of important boxes. It was randomized and sham controlled, and those are two of the most important things in trying to objectivity of a clinical trial. So we like that. It's not a trial in isolation. It builds on previous data as well. So that's an extremely positive aspect of the trial. Lots of device trials are not well designed. They're really quite haphazard, with poor design, small numbers. So in that sense, much better than most device trials. But it, compared to the drug trials, is tiny. I mean, very, very small study. And this is an important disease. If you were studying a very rare disease, then 100 patients would be a big trial. But this is no stretch that this could possibly be imagined as a rare disease. It's not. It's an extremely common disease. And in that setting, we need to have a much higher burden of proof. We need to have studies that give us real certainty, because if we're going to roll this out and use it in thousands, tens of thousands, even hundreds of thousands of patients, then we need to have huge certainty that actually it does work. So relative to the importance of the disease, I would argue that this is really a very small study, far too small. I think it shows a benefit. I think that benefit is real, but it's very small. So how much impact would that have relative to the inconvenience, the cost, and the degree of uncertainty about risk? I mean, there is no safety signal coming through from the data at all. So everything we see so far tells us that it's safe. But there was, say, for example, an increase in patients converting from dry AMD to wet AMD. You would need a bigger trial to look into that further. Let's say that this device has some negative impacts. Maybe it does convert some patients from dry to wet AMD. That's not proven, but it's not disproven either. So we need a much bigger trial to work out with certainty that any rare events, any safety events are well detected, and 100 patients is generally not enough. But it does rule out significant safety, and there's none so far. In terms of geographic atrophy, as I say, it's inconclusive. We don't have the answer to that question yet, but it would be interesting to see further studies. So it's important that people who are considering the Valeda device match those in the trial. I know I've said that about 3 times now, so I know I'm going on, and apologies for that. But if you don't, then these results won't apply. And if we're uncertain about these results, we're definitely uncertain if you don't match the same patient group. So very important that you get in front of someone who can tell you whether or not this trial would be appropriate. In terms of future studies, I think the technology shows promise. As I say before, I think we should be encouraging to the data that we've seen already. I think there's some positive outcomes to this. But if we want to be sure, then we definitely need a much larger trial, both to establish that it works, to establish how much of a benefit it creates. Is it really worth it if the vision is indeed very small in terms of improvements, and to make sure there aren't any rare safety events. As I understand it from the company and looking at some of the publications, it is also being tested for other conditions. So it looks like they'll be exploring it in other diseases such as diabetic macular edema, some other conditions called central serous chorioretinopathy. So it looks like they will be exploring other treatments. But for today, for this evening's talk, I'm really just going to focus on dry AMD. So I've tried to fill about half the time with the talk, but I'm very open to questions. So maybe I'll hand back to Kathy to moderate. Thanks for listening.
Thank you very much indeed, Tim. That's absolutely brilliant. So if you would like to stop sharing your screen, we'll crack on with lots of questions. We have lots of questions this evening, so promise to get as many as we can. So I just want to clear up some things right from the start, because we have quite a lot of questions about other red light devices. And as you said, there are already treatments that, for other conditions where red light or light therapy is being used. We're just talking tonight really about Valeda, aren't we? The evidence is for Valeda. So as far as we know, there is no evidence at all for any other, no serious evidence for any other product using red light for AMD. Neither you nor I are aware of any serious evidence for any of these other devices, I think is. So we're really just talking tonight about Valeda. And I guess that we had Professor Glenn Jeffrey talking to our conference last year in September about red light, and he was very interested in the technology as you are, but very cautious about all the things that are currently on the market for which there is very little evidence, and is urging people really not to to be very careful when you go out and buy these untested machines. And of course, just because a machine has been designed to improve skin doesn't mean to say it's going to be any good for the inside of your eye, does it?
No, I would completely agree. And I've tried to be as sort of balanced as I can in terms of this technology, because I think there's definitely some reasonably good evidence out there. But lots of these other things, we just don't have that. We just don't have that reassurance. And although, often ophthalmologists will go, well, it's probably safe because it's only light, if you know what I mean. But I think we should be that sort of relaxed about it. Light, as we've shown already, can cause, changes in the biological system. So just because something is, thought of as being fairly harmless, we need evidence to show that it is safe. So, unless there's good evidence, I wouldn't be buying something, cheap from Amazon in the hope that that somebody says it works without reasonably good evidence. And I think we're in the watershed with this particular technology. Those other ones, it just isn't anything like enough data out there to really support their use.
So just going back then to the size of the trial. So there are three trials. There have been three trials, haven't they? LIGHTSITE 1, 2, and 3, and LIGHTSITE 3 is the biggest, with about 100 patients in it. Just to put this into perspective, what would be considered an acceptable size trial, do you think, to really generate some real confidence in the technology?
Yeah, it's a really good question. It's one you could spend about an hour answering, actually. So you've got to decide. There are two elements to this. One is safety, and one is effectiveness. Now, for effectiveness, you could argue if you've got a positive result with 100 patients, why do you need any more? You could just say, well, look, we've hit those statistical mathematical thresholds to say there's a significant difference. Job done. So that is one approach to it. I would still argue that you generally like to have confirmatory studies. So, for example, for drug trials, they'll usually require 2 trials. I mean, it's a bit of an artifact, in fairness. It's slightly contrived, but generally speaking, we like to see more than one trial showing that pointing in the same direction. But to get to your sort of answer, I think if I was to look at this, the kind of trial size I'd be expecting to see, to have a reasonable chance of picking up on safety, to confirm the results we've got already, would be in the region of about 400 patients. Now, 300 might be fine, because it might be that you can combine the analysis with the 100 you've got already from LIGHTSITE 3. You can combine the analyses. But in that kind of a region, I don't think we necessarily need to do the drug trial, 1,000, 2,000 patients. That's probably overkill. But generally speaking, a few hundred would be about what you'd expect to be confident in the result.
And I think this is quite important, because, as we know, this treatment is widely available, but people have to pay for it. It's not available on the NHS. What would be the possibility of this being approved by the NHS for use in the NHS by the National Institute for Health and Care Excellence? NICE. Every new therapy of any significance has to go through this, doesn't it? What would be the chances of that happening on the biggest trial of 100 patients?
It's a really, really good and pertinent question. So for my sins, I spent 10 years sitting on the NICE IPAC committee, which is the one that looks at devices and decides whether or not they should be decided for routine use, or should it be only under sort of so-called special conditions where you watch closely at the results to get a bit more information, or should it only be done within the setting of a research trial? Now, when we sat on that, again, it comes back to a point I was making earlier on. If this was a rare disease, then you'd often be quite happy to let a trial of this size go through, and you'd say, look, they've done really well. It's a hard trial to recruit. We're not going to get a trial of 1,000 patients with a rare disease. It's enough. That would be signed off, and the committee would generally say, yep, that makes sense. The million-dollar question is, if this technology was taken to the NICE IPAC committee now, would they flag it through, or would they put cautions on its use, or would they should it only be used in a research setting? Now, it's not easy to make that prediction. It's a committee. People have different opinions. But if I were to hazard a guess, I think at the minute, if they went to NICE, they would probably not get so-called standard arrangements. I think NICE would probably put some restrictions, say, look, if it's going to be used, it needs to be done in a setting where people are collecting and aggregating data. Or they may very well say, look, we need more research. It's such an important disease. We just need better data. And I think if I had to put my money on an outcome, I'd say it would probably be given research only. Now, I can make these predictions because I'm not on the committee. But I think it would probably be labelled as research only as things stand.
Okay, which of course limits its availability to people who for whom £5,000 a year is actually quite a lot of money, isn't it, for most of us, to be fair. So just to get back to the therapy itself, we have quite a lot of questions about the wavelengths. So you were very specific about the wavelengths, and there are 3 used in the Valeda. How important is this wavelength thing? Because there are lots of other products using different wavelengths. So how important is the wavelength?
Yeah, so it's a slightly hard question to answer, because actually if you were going to do the trial, you'd want to do different wavelengths. You'd want to trial one wavelength against another and see whether or not one produced more benefit than the other or had a better safety profile. But the science behind it is that the different wavelengths target different bits of the mitochondria. They have different effects. So remember, I was talking at the beginning how there's a range of different functions that the mitochondria perform, and there's a range of different things that can go wrong in the mitochondria. So, for example, one of the wavelengths might work on the nitric oxide, or trying to increase blood flow. Another one might try to improve the production of ATP. So they're designed to have a different target, albeit within the same part of the cell. So there is science to it. There's some logic that these are the right wavelengths to use. They're, if you like, set up for this particular machine. It makes it harder for someone else to mimic those kind of doses exactly. But I think generally speaking, there's reasonable scientific underpinning for the doses that they've got.
And the combination is important, possibly as well. Then, so okay. Now, a couple of people pointed out that this so-called sham arm in the trial, the people who weren't treated with these wavelengths. 2 things really. One is that it suggested that actually there was some treatment in the sham arm, just not as much as the so-called treated arm. Is that right? Is that your understanding?
Yeah, well, yes. So it's an interesting question. So as I was kind of talking a little bit about before, but in essence, when you see that kind of result, you think, well, what's going on in the control arm? Now, it could be, for example, that, and I wasn't involved in the clinical trial, so I don't know how the sham was set up, but it might be, let's say you provided a lower illumination, a non-clinically meaningful illumination in the eye. Maybe, that was producing some benefit. That's one possibility. The second possibility is that patients just got better they learned how to do the visual acuity charts. If you sit someone down and you test them 10 times in a row on a visual acuity chart over different days, so that they don't get too fatigued, they often get better at doing it. There's a so-called learning effect. So so you then attribute it to your intervention, and you go, oh, look, my treatment's improving the vision. It might actually be that the patient's just getting better. And that's actually easier to happen than you might think. So when someone does an eye chart, they'll often go, I can see that one, A, B, F, G, and then they stop. They say, I can't see any more. And then if it's not done carefully, then that will be their vision. But actually, if you go to them, look, I'll give you £50 for every letter that you read correct, their visual acuity will improve. They'll push themselves to the point that they really are failing, and they'll get down another 2 or 3 lines. So testing a visual acuity is not quite as precise as you might imagine. And then it can happen by chance. You won't get a result where it's sort of 0.00 change. Do you see what I mean? There will always be just a bit of noise in the system. Patients can get a little bit better, a little bit worse. So it's not uncommon that, in fact, you do get some variability.
And another question, there's a few more questions coming in here. One is, was it a sham or was it a placebo? So there's quite an important difference, but there's similar concept, aren't they?
The concept is the same. That's right. So if we're giving someone a sort of a sugar-coated placebo tablet, you'd call it a placebo. But typically with devices, if you're trying to mimic an active treatment, we call it a sham. But methodologically, they come to the same thing. It's trying to simulate treatment, so neither the patient nor ideally the treating physician know what's happened.
So can you have a placebo effect in a sham arm? Does the same sort of psychological response happen?
Yeah. So that's very true for some. Let's say, for example, you were giving treatment for mood. If the patient thinks that they've had an active treatment, it might improve their mood. They might start to feel a benefit. In fact, there's even stuff to show that whether or not you give a small tablet or a big tablet, they can have a different placebo effect. So yes, that's true. It's hopefully a little bit less of an issue in a trial like this, if the person testing the vision is doing it very, very carefully, they will hopefully push the patient to their really struggling with their visual acuity testing. So you try and design the trial to minimize that effect. But yes, there can be an effect, but the issue is that should have applied at the beginning, potentially as well. So yes, you might get a bit of an improvement if the patient thinks, gosh, I think I've had this active treatment. I'm going to try extra hard on the visual acuity testing. But if it's done perfectly the first time, they won't have any improvement because that really was their true threshold.
Okay, and another point that this we've concentrated on improvement in vision, but somebody in the chat quite properly points out that actually for many people stabilization of vision is actually really, really important. So as long as they're not getting any worse, they consider that a success. And of course we do have that attitude to wet AMD treatment, don't we? We know that some people may have a small improvement in vision, but actually that's not the aim, is it? The aim is the stabilization of vision, and that's why early treatment is really important, so that you stabilize at a very high level of vision. So in concentrating on the improvement in vision, might we be underestimating the value of this?
Yeah, it's a really good point. And actually, it's one thing that particularly for the US regulators that companies can struggle with, because often they'll require them to show this vision improvement. But exactly as you say, if maintaining vision is the main outcome, then that's a completely valid outcome measure. The issue with preserving vision is that you often need a very long trial. It's often not financially viable to do that because AMD is a disease that most typically the vision goes down very slowly over a long period of time. So let's say it's going to take, I'm going to make up some numbers here. Let's say it's going to take 3 years for patients to lose 5 letters, for example. And you want to you've got to let the vision drop down a bit in the control group to start to show a difference if you're maintaining vision in the active group. So you often have to run very big trials for a very long period of time to show that the vision is maintained, because the change is usually so very slow. And that often makes it not financially viable to run those trials, even though the question is incredibly valid. And that's why they'll often go for the shoot the lights out improvement in visual acuity, because you can get there quickly and show an impressive change. In fairness, if you can show an improvement, then chances are you're obviously going to be maintaining vision as well. But you're right, if there was a maintenance of vision, but there was in the control group in the study. You see what I mean? The control group gained vision was actually the natural history, the natural progress of dry AMD is usually a gentle decline in vision over many years.
Yeah, and so this is why visual acuity is no longer really an adequate measure, is it, to help get these clinical trials going and affordable? So we need to find other, what are they called, clinical endpoints of the trials, aren't they? The thing that you're aiming at in the trial needs to be different, really, if we're going to be able to show that there's an impact on the disease progress before people lose their vision, which is what we're all trying to do, really, in the end, isn't it? Not prevent the vision getting worse or slow the vision deterioration, but actually prevent it getting to that point. So what else could be used potentially? I mean, the size of drusen or the number of drusen, or are there other potential measures that we need to look at that would help?
Yeah, it's a really good question, and actually one that people spend a lot of time debating and thinking about. So as I say, the regulators will often focus very much on visual acuity. So that's something we're all very, very familiar with. But there are other metrics. So it may be, for example, the patient can see the eye chart, which is a dark black letter on a white background, but the real world doesn't have that black and white contrast. The real world is filled with lots of gray. So actually it might be that if it's so-called low contrast acuity, so a visual acuity that doesn't use a black, dense black on a bright white, may better reflect what patients notice in terms of their symptoms. So visual acuity is not everything. The big one that is really coming up with dry AMD studies is the area of geographic atrophy. So this trial did look at that, but it didn't show a statistical difference in the expansion of the geographic atrophy. There was no statistical difference between the two groups. But for a lot of the other trials, they have shown. So as you'll know, some of the injections for dry AMD have been shown to reduce the expansion of geographic atrophy. And the regulators were happy to accept that. They were happy to accept that, the US regulators at least were happy to go, well, we know that expanding geographic atrophy is a bad thing, that it will ultimately affect the vision. So we'll accept that. We'll accept that an expansion of geographic atrophy is a so-called proxy for what's going to happen in terms of the vision. You don't have to run the trial for 20 years. We'll give you permission to sell the drug at this stage. But other regulators and, NICE, for example, will go, well, do you know what? It doesn't really matter what's happening with the geographic atrophy. If the patient isn't, if we can't measure an improvement in visual function, it doesn't matter what's happening structurally in the back of the eye. We've got to show a benefit, a direct benefit to patients. And that debate continues. We don't have an answer on that. There are different views on what are the best outcome measures. But your point is exactly right. It's not just about visual acuity.
So, I mean, one of the pieces of work that we're involved in is our project Action Against AMD, and one of that streams of work is using eye scans and artificial intelligence to try to identify these earlier markers of the disease. So we can show just by vast amounts of data that, yes, this absolutely is an indicator of disease progression, and we can perhaps get there a bit earlier than waiting for visual loss, which would be really good. And I think it's true, isn't it, that in other disease areas, anatomical changes are taken as a proxy for an improvement in the disease. So it's a battle that we've got to win really in ophthalmology rather than sort of as a principle in medicine as a whole, I think. Is that right? Have I made that up?
No, I think that's fair. I think so I might say I sit on the fence on this, but I think we don't want to be slavish in terms of saying visual acuity is the only metric that we use, because I think that's wrong. It's not fair on patients to require a trial that's not deliverable, because it obviously won't happen, and good technologies might get thrown to the wayside. On the other hand, if you have a small area of geographic atrophy that's nowhere near the fovea, it really isn't going to have an impact on vision. So we don't want to rely solely on there has to be that link between visual function and structure in the back of the eye. And so that's where the work you're doing is so important, because bringing those two together to work out which structural outcomes matter and how they translate to visual function and the patient's benefit is essential, because otherwise the conversation will just go round and round in circles.
Somebody else has asked about oxygen therapy. Does oxygen therapy have any impact on mitochondria? Do we know?
Yeah, so look, I'm not an expert on the use of sort of hyperbaric oxygen and those kind of things as well. There is some data out there, but it's not something that we advise. It's not something where the data, I think, is good enough to recommend it. So a lot of it's been, I don't know if they're talking specifically about hyperbaric oxygen. It often is that question. And if that is the sort of nature of the question, then at the minute, I don't personally feel there's good enough data to advocate it. Okay,
thank you. Another question here, which is, looking at the cost of the treatment, Valeda, the cost, the limited size of the trials. A few people have asked about, in order to mitigate the risk, the financial risk and any other risk, what about having one eye treated? Because, if there's nothing else, then treat one eye. At least you might get a benefit without the full 100% risk involved in treating both eyes.
Yeah, it's a good question. It's not something I've thought about before, actually. It'd be interesting to see what their pricing template is, because if you've got the patient sitting on the machine, it's not necessarily that much effort to treat two eyes over one eye. So I don't know whether or not, if I was to guess, I would say it might be that one eye is not half the price of two, for example. But again, it's something I'm just not privy to that information because I don't offer the treatment myself. But I guess it's a question you could ask. I guess in the question, would you treat the better eye or the worse eye? If you're treating the worse eye and you get a benefit, that's not necessarily going to be make a difference to your overall vision. So you could argue, well, I'll do the better eye because that's the one that's going to give me the greatest advantage. On the other hand, if you are worried about safety, and I don't think there is a safety signal. I don't read the data we've got so far as being concerning. But if you say, do you know what, I'd rather have a bigger volume of data before I commit to this, then that would push you to treating the other eye. Do you see what I mean? You might. Very hard to know how you would handle that. It's not.
And that's
logical.
Because overall visual acuity is determined by the better seeing eye, isn't it? Which is why somebody who can only see out of one eye can still have 20/20 vision effectively, because if the other eye is working, then that's what determines the acuity. So just several questions about. Okay, so let's do another trial. Let's do another trial then. Question directly, given the importance, will charity fund another trial? will it be years and years before we get a 400 plus participant trial? How do we go about getting the next trial done to answer some of these outstanding questions, if you like?
Yeah, it's a really good question, and keep in mind, it's always very easy for me to say we need a bigger trial. I mean, it's very easy to sit here as a sort of a person who designs trials and everything, and then go, yeah, fine, exactly, yeah, just do another trial. And we've got to have some sympathy for the company. These companies say they don't have enough money to run massive trials. They have to start selling it to survive. They can't run trial after trial after trial. They have to start getting some income, and it may be that they have an anxiety about running a bigger trial, because that sends out a signal that we're not there yet. What they want to do is they want to start selling to pay their staff to survive, to move forward. Maybe someone will come in and buy them, and they'll make a whole bunch of, they'll be able to cash out and make a whole bunch of money. If you then say, right, well, actually, do you know what? We haven't got enough data. We need to run a bigger trial. That sends out a signal that actually we're not there yet. Do you see what I mean? So I don't get the feeling that the company has a great appetite to run a big, the kind of trial I would desire, because that might sort of scupper the market for them in some way. I would still argue very strongly that we do need the trial, and the question is how do you make that happen? Now, if the company aren't going to do it themselves, and I can't speak for them at all, but let's assume they're not, then you're looking for one of the big sort of UK funders, ideally, to run that trial. So the obvious port of call will be the NIHR, who run trials of this size for important conditions. I think it would tick a lot of boxes with them.
NIHR is National Institute for Health Research, which is effectively the NHS's arm, isn't it? The government NHS research arm.
Yeah, good point. I should have made that clear. I'm sorry. As it's like, yeah, when you live in this world, you forget that it's not a common term. So yes, the NIHR basically is a big NHS funder, and they fund trials that answer important questions, usually to a very high standard. So that would be great. If the NIHR were interested in funding this, I think that would be a great thing. As I say, we'd probably need the company to at least go along with that. And as I suppose, I imagine those discussions are ongoing. I think you might be muted.
I beg your pardon. We need the company to help because they own the machines, don't they? They own the patent on the machine, so you can't, And I think somebody put in the chat here, they're quite expensive machines, 46,000 euros, I think, per machine. Somebody put in the chat earlier, and he says he knows because he has one. So actually, the cost of a big trial could add up quite quickly, couldn't it, if you were looking at those sort of costs? So
it's an interesting point there, actually. If you ran the trials for something like the NIHR, it would be in the region of ballpark figure to maybe 2.5 million or something like that. If the company had to do this through as a commercial trial, they're talking maybe 10 or 20 million dollars. So it's very good value to run an NIHR trial if there's a will to do it.
Yeah. Well, we'd certainly, to answer the question about charity funding, we'd certainly be interested in helping. I'm not sure we could manage it all, but yes, we'd be very keen to help and support any idea that we went forward on this. So, Tim, thank you very much indeed. We're very nearly at the end. Just to wrap up, what's your absolute top line take home message over this?
I think it's promising.
We've been down lots of avenues, haven't we, on this?
Yeah, I think it's promising. Message. I think there's something in it. I think there's promise. But I personally think we need more data.
Okay. And in the future, I like to ask this question of people, in terms of, I don't know, light therapy or injection therapy or oxygen therapy or whatever. Where do you think we're going with AMD, and what's your hope then, do you think, for the next few years? And
so the great thing is there's lots and lots and lots of research. I think the companies have seen how much money they can make out of wet AMD, and they think, crikey, dry AMD is even more common. I want a slice of that. So I think there's no one answer to that question, but there is a lot of research going on. So I think it's an incredibly exciting time for research in terms of dry AMD.
Are you an optimist then?
Yeah, no, I am. I think it'll be slower than people hope. I think things will take longer than people realize, but I think we're definitely moving in the right direction.
Tim, thank you very, very much for giving up your evening for us. It's been a really fascinating and interesting talk. I'm sorry there are questions that we didn't get to, but thank you for all your pre-questions and the questions in the chat. And don't forget that we've recorded this. So if you've missed anything or you know of anybody else you think might be interested in this, do point them to our website, because in a day or two, the talk will be up on our website, on our YouTube channel. You'll be able to watch it again and again and pass it on to other people who you think might be interested in. We'll be back next month for the June My Macular and Me. So watch out on the website and on social media for what the topic is for next month. But in the meantime, Tim, thank you so much again. Thank you very much indeed, everybody, for joining us. And I hope you have a lovely evening, and we'll see you soon. Thanks very much indeed. Good night, everybody. Good night.